Good evening, everyone. So we'll start with echo evaluation of prosthetic mitral valves. Again, this is part of the basic series. So this is not really the focus is not going to be people who are very well versed with doing echo or even assessing prosthetic valves. But I'll be showing you a few cases, a spectrum of cases, and hopefully people who are starting off or who don't feel very confident about this topic of handling prosthetic valves, hopefully there will be something to take from this. So I'll try to keep it very simple, and also there will be much repetition even from previous talks, just so that we can remember better. So prosthetic valves means artificial valves. So like I said last time during my talk on aortic valves, so grossly these are the different valves that we see. This is the bileaflet valve because there are two leaflets. And as you can see, there's a smaller central orifice and there are two lateral orifices which are a little bigger. Likewise, this is a single leaflet tilting disc valve, which again has one bigger orifice on this side and a smaller orifice on this side. This is a ball and cage valve. So you have a cage and you have a ball. That is why it is called as a ball and cage valve. And then you have bioprosthetic valves. All these others are bioprosthetic valves, which means it is taken from animal tissue. It could be from pigs or from cows or any other animals also. These are the common animals whose pericardium is generally used to make these valves. So this is what is called as a stented bioprosthesis because there is a stent, as you can see, and the tissue is mounted onto the stent. This is also a stented bioprosthesis. And then these are, of course, the transcatheter valves. So broadly, this is how you can classify prosthetic valves into biological valves, which may be stented, stentless, sutureless, transcatheter, or mechanical valves, which, as I said, can be bileaflet, single tilting disc valve, or ball and cage valve. In our country, we still see a lot of these mechanical valves, especially patients who have had their implants 15, 20 years ago, or even later than that. So we still do see a lot of these valves, and majority of the valves that we see are mechanical valves. There are some bioprosthetic valves which are surgical, and few are transcatheter valves. However, the numbers for these bioprosthetic valves, as time goes by, we'll see more and more of it. So these are just some magnified pictures which show the ball and cage valve. You have a ball, you have a suture ring. So this is what fits into the patient's annulus, be it aortic or mitral or whichever valve. And today we are going to be talking about mitral valve. So this is going to be seated in the mitral annulus after the surgeon takes out all the diseased native mitral valve. And this is what is going to be sutured to the mitral annulus. So you have a cage and you have a ball inside. This is a single leaflet tilting disc valve. Again, you have a suture ring or sewing ring, SEWING, and then you have these what are called as struts. These wire or kind of things which are firmly seen holding the disc are called struts. And sometimes you can have breaking of the struts, fractures, etc. That is a single leaflet tilting disc valve. And this is a bileaflet valve where you have two leaflets like this. And then you have, of course, hinges. These are more like windows, if you can imagine. And this, of course, like I said, is a bioprosthetic valve, a stented bioprosthetic, because there is a stent, as you can see. Now, it is important also for us to know what is the probability of an event in, say, 15 years. So this is based on evidence. As you can see here, in the long term, bleeding risk is generally more with mechanical valves, that is metallic valves, because they need to be on more intensive anticoagulation. So cumulatively, the risk of bleeding over time increases. And the perivalvular regurgitation or paravalvular leak, as we can call it, is also greater with mechanical valves. However, structural valve degeneration or deterioration, SVD or primary valve failure, is more with bioprosthetic valves. So what that means in short is mechanical valves are very durable. Bioprosthetic valves may deteriorate over time, and they may need a future procedure also. However, the long-term risk of bleeding and paravalvular leak is higher with mechanical valves. The thing to also know and keep reminded of is the fact that all prosthetic valves have some amount of obstruction. And the smaller the valve, the greater is the likelihood of the obstruction. That is also something that we looked at last time. So they are not like native valves. Tissue valves may come closest to native valves. So this is the flow profile across prosthetic valve. This is a bioprosthetic valve. And this has more or less a laminar flow, as you can see. And this is a bileaflet valve, wherein through the central orifice, you will have a higher velocity because it's a smaller orifice. And the lateral orifice will have a lower velocity because they are relatively bigger orifices. So that is also something to know, something I mentioned last time also. Sometimes while measuring gradients and all, we can put our cursor through the central orifice and we may get higher velocities and higher gradients, in which case we may need to shift to one of the other orifices and see if there is any change. That is something to just bear in mind, especially with bileaflet valves. Now, the other thing, what we talked about even last time is that all these valves intrinsically have some amount of regurgitation that you can see. For those of you who are not very familiar with these images, nothing to worry. These are all trans-esophageal echoes only, in which case what you are seeing on top is the left atrium. Unlike the transthoracic, where you'll see the left atrium at the bottom, these are trans-esophageal echo images, TE images, and hence the LA is on top, LV is at the bottom, and the valve, prosthetic valve, is in the middle. So these are the different shadowing patterns and reverberations that you see with the various valves. So here you have the ball and cage valve, here you have the single leaflet tilting disc valve, and here you have the bileaflet valve. And they all have a characteristic pattern of physiological regurgitation, which has been shown here in these pictures. So this is also important to bear in mind, because this will help us differentiate from pathological or regurgitation, which is due to disease. So these are normal jets that you will see when you have a prosthetic valve in the mitral position, especially if you are doing a TE. It happens for two reasons. One is the valve, as the valve closes, it displaces a certain volume of blood, and that causes a jet. That is number one. Number two is the valve is built in such a way that there is some regurgitation which is allowed, so that blood clots don't form and thrombosis doesn't happen. It is a protective mechanism. So all of these valves have some amount of regurgitation. That is just for information that I've just put it up here on the side. So bioprosthetic valves, like I said, are closer to native valves and hardly have any regurgitation, whereas the metallic valves generally will have up to 10 ml of regurgitation. Before we proceed with any study, this is something that we mentioned last time also. We should ensure that it is the right patient, the demographics, the hospital number, all those details are done properly. Height, weight, and body surface area is essential. Date of the surgery is extremely important, because from that we will know certain conditions which may occur closer to the surgical date. Certain other conditions may occur a little more remotely. So that is why date of surgery is important. What valve was implanted is also extremely important. And you will see why as we go through the cases. And it is also good to see what was the baseline post-op echo and subsequent serial studies, because that will enable us to compare what was the valve like, what was the motion of the disc like, what was the gradients like, what was the LV function like. All those serial comparisons we can do when we compare the different studies. And also whether the patient has been taken anticoagulation is also very important, because somebody who is on a metallic valve has stopped anticoagulation is likely to develop thrombus or blood clot, and is likely to develop an obstruction. So that history is also very important, especially when we see high gradients, and especially if the valve is not very old, like it's just a few months and the patient is symptomatic, patient has stopped anticoagulation, we think of a thrombus. And what are the symptoms of the patient? That is also extremely important. That helps us to compare between a symptomatic patient, between a patient who is not symptomatic, and in the light of that, interpret our findings also. Also, we need to know about these high output states, because all these will have an impact on the gradients also. So this is from the 2017 guidelines, this table which I had shown last time also. It's all freely available. We can go through this. So essentially clinical information, we look at how is the valve, how is the motion of the leaflets, how are the cusps, is there any thickening, all those details, calcification, what are the gradients like, and different Doppler parameters, what is the impact on the chambers, is there any dilatation, any dysfunction, all those things we get. So for the mitral valve, we will be looking at all of these things through cases, but essentially it is a peak velocity, mean gradient, VTI, DVI or Doppler velocity index, effective orifice area by continuity equation, pressure half time, then of course other things like the LV size, function, and the pulmonary pressures. And of course, you must look at the other valves also. Sometimes we may get so engrossed looking at the prosthetic valve that we may ignore certain other findings in other valves. So that is also important, doing a systematic study, looking at all the valves carefully. So these are the parameters that have been enlisted or enumerated based on the 2009 prosthetic valve guidelines of the American Society of Echo. The European Association of Cardiovascular Imaging has subsequently in 2017 come out with their own guidelines, which are somewhat similar. They have a lot of pictures and illustrations and things like that. So that is so these are two guidelines you can refer to for the sake of assessing prosthetic valves. So now, if we look at this table I will be referring to again and again, and I don't wish to go through too much of information, but try to use different illustrations, different case scenarios to highlight these very same points. So these are the normal parameters. So when I say peak velocity, we mean the peak E-wave velocity is less than 1.9 in the normal person. Mean gradient is less than or equal to 5. The DVI or the Doppler velocity index, which is a ratio of the prosthetic mitral valve VTI by continuous wave Doppler, and LVOT VTI by pulse wave Doppler. The ratio of these two things is what is called as a Doppler velocity index, and that is less than or equal to less than 2.2. Effective orifice area, which we will see how to calculate, is greater than or equal to 2, and the pressure half time is less than 130. And what suggests significant stenosis is a pressure half time of greater than 200, EOA less than 1, a DVI greater than 2.5, and a peak velocity greater than 2.5, that is the peak E-wave velocity, mean gradient greater than 10. And anything in between we label as possible stenosis. So these are the different categories. These are just some numbers to remember broadly. As we go through cases, I hope it will get reinforced. So we come to the first case. This is a 31-year-old female had a mitral valve replacement in May 2019, that is last year, with a 31 mm TTK Chitra valve, which is a single leaflet tilting disc valve. The patient is asymptomatic, just comes for a routine checkup. So this is how the valve appears. It has got a very prominent ring and the struts that you can see quite well on the X-ray. So even when I show the cases, you will be able to appreciate the different X-ray appearance of these valves, which will also give a clue to what valve has been implanted. So this is a Chitra valve, single leaflet tilting disc valve. And this is the parasternal long axis view. As you can see, this is the disc that is seen here. And you can see quite good laminar flow across the valve. This is a zoom view of the mitral valve, and you can see this disc, which is nicely moving. It is attached here, and this is the larger orifice. So just make note of these things because this is important. And this is the zoomed four-chamber view, as you can see here. And again, you can see the disc here with nice motion. This is the same thing with color, and you see good laminar flow. There's a bit of tricuspid regurgitation, but the velocities are not high. So there is no pulmonary hypertension. And this is the LVOT VTI that has been taken here, traced here. And this is the mitral VTI and the pressure half time. So all the values are given here: peak velocity 1.46, mean gradient of 3, Doppler velocity index of which is a ratio of the mitral VTI to the LVOT VTI. That is why I have put it side by side, so that we know that it is a ratio of these two VTIs, that is velocity time integral, that we get a ratio of 1.47, and pressure half time is 69. So just coming back to the table, this patient has a peak velocity of less than 1.9, a mean gradient of less than or equal to 5, VTI is also less than 2.2, pressure half time is less than 130. So these are the numbers. Everything fits in on this side of the table, and hence this is a normal study. Now there are different conditions which can cause an elevation of the E wave velocity or the peak velocity and the mean gradient. So it is good to know what are these conditions, and if once we know these conditions, then these are the things that we will be looking for in echo also. So it could be, most importantly, stenosis, and pathologic stenosis can be as a result of thrombus, pannus. These two may not just need not just occur in isolation. They can be a combination of thrombus over pannus or degeneration in case of a bioprosthetic valve. I'll be showing illustrative cases for most of these things. Then the second category would be high flow, which is as a result of tachycardia or anemia or pregnancy or patient prosthesis mismatch. So here, there is no real problem with the valve as such. Either the flow is increased or the valve is too small for the patient, as in patient prosthesis mismatch. So nothing wrong with the valve. The valve is a good valve. It's just that either the surgeon has decided to put a small valve and hence it is small for the patient, or there is too much flow across the valve, as a result of which there is functional stenosis. The third category is those with significant regurgitation, which may be through the prosthetic valve, as in bioprosthetic valve degeneration, or it can be a paravalvular leak or a periprosthetic regurgitation. So these are all conditions in which you can get high E wave velocity and increased gradient. So not all increased gradient is pathologic stenosis. That is important to note. That is what we learn from this particular table. So just putting a continuous wave Doppler across the mitral valve and saying gradient is 10, there is obstruction, is not correct. So there is no single parameter to tell us that there is obstruction. We have to take all these findings, different parameters into account, and then come to a conclusion as to whether there is obstruction or not, or what the problem is. So the first thing we looked at was the peak E-wave velocity, the mean gradient, which we got by tracing the mitral inflow VTI. That is this, by continuous wave Doppler, we got this trace, and then we did the tracing of this to get a mitral VTI. So that will also give us the mean gradient as has been shown here. So peak velocity, mean gradient we have looked at. Now this second thing would be the effective orifice area. So this is how it is calculated. Like for the aortic valve, the first step is to take the LVOT annulus or the aortic annulus. So that I'll come to it once again because that is extremely important. It kind of defines the standard of the echo that we do. How we measure the LVOT annulus is a reflection of how good and how serious we are about doing an echo. So in fact, if I can say, there are probably two things that can define quality. One is how well we trace Simpsons, and two, how accurately we are able to measure LVOT annulus or aortic annulus. So the first measurement is LVOT diameter. Then is the LVOT VTI, which we take from the apical 5-chamber or the apical 3-chamber view by a zoomed view, pulse wave Doppler close to the aortic valve, but without any kind of spectral broadening. That is the LVOT VTI. And the third reading that we need is that of the mitral VTI obtained by doing a continuous wave Doppler across the mitral valve. So on the numerator, we have LVOT stroke volume, which is a product of LVOT cross-sectional area, which we get by LVOT diameter. LVOT diameter, we get the radius of the LVOT, and hence pi r square there will give us the LVOT area. That is what we get here as cross-sectional area. That times the LVOT VTI, which we got from here, the product of these two things by now we know is the stroke volume of the LV. The stroke volume of the LV divided by the mitral VTI gives us the effective orifice area of the mitral valve. So we can go wrong in any of these steps. If we underestimate the LVOT VTI, our effective orifice area is going to be small. If we overestimate or underestimate the transmitral gradient, then the effective orifice area is going to be falsely high. Likewise, if our radius is not properly measured or the LVOT diameter is not properly measured, then again, if it is underestimated, which is often the case, then again, effective orifice area is going to be affected. So these are all different ways in which we can go wrong. We have gone through this in detail the last time we talked about prosthetic aortic valves. So this is, like I said, one of my favorites to talk about and very relevant. So we take a zoom view of the aortic valve and we freeze it like is shown here in systole when the valve is fully open, and then we measure from annulus to annulus. That is the hinge points. We measure from the hinge point from the blood tissue interface here to the blood tissue interface here, and that gives us the LVOT diameter. Now it is important to make sure that the LVOT is fully open, aortic valve is also nicely open, LV is also properly centered. That will give us the maximum diameter of the LVOT. If it is oblique or something, then we can underestimate the LVOT diameter. So we should, we have also seen numerous times about what will happen if we measure at odd different levels. So that is why we should stick to one point, which is the fibrous skeleton, and that is the annulus. So annulus corresponds to LVOT diameter, and we stick to that so that there is no study to study variation, and also there is no variation in different conditions like LVH or sigmoid septum or things like that. So that is why we measure at the LVOT at the annulus. This is how we measure the pulse wave Doppler of the LVOT, VTI. So we keep it close to the aortic valve, ensuring a nice crisp trace like this. And we trace the modal velocity. We already said what is the modal velocity. It is just a statistical term to say what is the most frequent velocity of the RBCs, or rather, what is the velocity at which most of the RBCs are oscillating or vibrating. So that is what is captured here. So if you see a wide range of velocities where the complete thing is filled, then you know that you are already in turbulent flow or in an area of turbulence. So you should avoid that, get a nice crisp flow like this, and that will be good. So this we talked about spectral broadening, wherein if we come too close to the valve, this whole thing will be filled up with a wide range of velocities. You won't be able to trace the modal velocity anymore. Whereas if you are too much into the apex, towards the apex, then you will falsely underestimate the velocity. That is why you need to go towards the apex, come towards the valve, and then settle down at a position where you get a nice crisp modal velocity. Another important thing to note is that the valve size is not equal to the effective orifice area. So this is the effective orifice area which has been shown in pink. This is the effective orifice area which has been shaded. So that doesn't correspond either to the internal diameter or the outer diameter. So that is important because it is the effective orifice area which finally impacts the life of the patient on how well he is doing, how well his heart is doing, how well he is symptomatically, mortality. All those things will depend on effective orifice area. And that is why this is so important to calculate by our Doppler methods. The next parameter, so we looked at E velocity, we looked at mean gradient, we looked at effective orifice area and how to measure it accurately. The next thing that we will be measuring is the DVI, or the Doppler velocity index. That is essentially, as has been shown here, a ratio of the prosthetic mitral VTI on the numerator and the LVOT VTI on the denominator. So this is what is the DVI. So for the aortic prosthesis, it's the other way around. So that is just to bear in mind. So for the aortic prosthesis, all values will be less than 1. Whereas here, we are talking of all values definitely greater than 1. So that is something to bear in mind. The final commonly used measurement in the evaluation of prosthetic valves, prosthetic mitral valve, is the pressure half time. Now, this is extremely important, and I would like to show you the importance of this through certain examples today. So as I had illustrated last time also, the acceleration time for the aortic valve is extremely important. Likewise, for the mitral valve, it is the pressure half time which is extremely important. So when we look at native valves, it's a little different. We would like to do a direct planometry by whatever means, by 2D, 3D, whatever is available. And then we say that that would reflect the valve area to the best possible extent. And then, of course, we rely on pressure half time even in native valves. But when we have a good planometry, that is what we go by. Whereas here, for prosthetic valves, the pressure half time plays a huge role, and that is something to bear in mind. It is, if I can use a parallel, use a comparison, it is something similar to aortic valve acceleration time. So if you already have in your minds the algorithm for assessment of aortic valve, wherein the last time we had seen about the different shapes of the aortic continuous wave Doppler contour, either it may be rounded or it may be triangular. And then we go on looking whether the acceleration time is less than 100 or more than 100. Like that, we can do the same thing without thinking that the mitral is very different. So that is the only point that I would like to make. So bear in mind the pressure half time. The pressure half time also has a relationship with the deceleration time, and it is 0.29 times deceleration time gives pressure half time. So especially if there is anybody giving any exams related to echo. So this would be definitely a question that might be asked, which is 0.29 times deceleration time gives pressure half time. Now, so pressure half time, like I said, is extremely important. And the reason is this. So we looked at the various reasons why you can have a high E velocity, a high mean gradient. That is what is shown here. All of, except a normal valve, all the other conditions you can have a high velocity or a high gradient. So high gradients can be seen in regurgitation, in high flow states, tachycardia, patient prosthesis mismatch, pathological stenosis. All these conditions can give rise to a high gradient, high velocity, high E-wave velocity. But the one thing that kind of, in most cases, will separate whether it is a stenosis from other causes of high gradients is the pressure half time. So that way, this slide is extremely important. So a pressure half time of greater than or equal to 130, we start thinking more in terms of stenosis. Whereas if it is less than 130, then we think of the other conditions. So that is how pressure half time, like acceleration time for the aortic valve, helps us in kind of separating what is obstruction versus what is not obstruction as a cause of high gradients. So we can also imagine what the shape of the inflow trace will be like. So like in the aortic valve, we said that if it more rounded it becomes, the more is the obstruction. So likewise here also, the less steeper the E-wave deceleration time slope becomes, or the less steep it becomes, or the more flatter it becomes, the more is the chances that there is obstruction. So anyway, so we'll look at examples, we will understand it better. So the first I showed you was a normal case wherein you look at the valve itself. Generally, it is good to keep the gains a little low so that you can see the mechanical valve well, and then try to appreciate what kind of valve is it. Is there any abnormal tissue that you are seeing? Is there any mass around the valve? So carefully inspecting the valve in multiple views, multiple projections is extremely important. So this is a 25-year-old female with a mitral valve replacement in 2009, a 27 mm St. Jude's valve, which is a bileaflet valve. And she is doing fine, except that she has some atypical chest pain, which often doesn't really correlate with anything serious as far as her valve is concerned. And she is on oral anticoagulation. So if you recall the previous X-ray, we could see the valve very nicely. Whereas here, this patient has had a valve replacement. You can see the sternal wires. So the patient has had a sternotomy. And this is the valve that you can see, which is very faint actually. So the St. Jude's valve doesn't really have a very, the radio opacity is not as much as a Chitra valve. So that is something to bear in mind. So you have to really lower the echo, the window and the contrast, and then try to see the valve, how it is and what kind of valve it is. So as you can already appreciate, the Chitra valve was easy to see. You already got a clue. Here you are not able to see very clearly, but you should try to look, lest you kind of write off saying this could be a bioprosthetic valve or something like that. So this is what the parasternal long axis view shows. So here you can see one disc. So in the previous example also that we saw one disc. Here also we are seeing one disc. These are the different views that we can see. So what is the difference? The previous patient also had one disc, but that was normal. Here, this patient we already know is a bileaflet valve. But many times that may not be known. We may not even know what valve. Patient may just come and say they've had a valve surgery. So we may not have any more details other than knowing that valve surgery is done. So then we, from echo and different means, we have to come to a conclusion as to what exactly it is. So this is extremely important to note. So here, when we have a history that it's a bileaflet valve, but we are able to see only one leaflet which is moving like this, then we start thinking of something not normal. So then we look at other views also. So as you can see, everywhere in all the views, you are seeing only one leaflet moving. And there is a lot of turbulence across the valve. So 4-chamber view, turbulence across the valve. Even the interventricular septum seems to be slightly under some kind of strain. And that motion is also not entirely normal. These are the gradients that we obtained. So as you can see, the mean gradient is 10, the peak velocity is over 2. LVOT VTI has been put here, and that's how we got a DVI of 3.36. Pressure half time is also greater than 130. So mean gradient is greater than 5, peak velocity greater than 1.9, pressure half time greater than 130. So these are certain numbers to remember. So I've just highlighted here for the sake of ease. So many times we may get parameters like this. So it's not like if we have a patient, all of them will be in this category, or all of them will be in this category, or all of them will be in this category. If it was so simple, then there's not much role for us to really try to spend time and try to figure out. But many times you will get values which are here and there. So that is the challenge, and that is where we have to kind of figure out, where is it a measurement error, first of all. Second thing, most importantly, it is we need to rule out a measurement error of all things. And then after taking all things into consideration, then we come to a conclusion as to whether it is truly stenotic, or whether it is a high flow, or whether it is a normal valve, whatever it may be. So it is after taking multiple things into consideration, the symptom of the patient, anticoagulation, all things considered, and then finally we can arrive at a proper conclusion. So these are the values for our patient. And this patient's pressure half time is greater than 130. Mean gradient is also 10, greater than 8 according to this algorithm. So most likely this fits into a obstruction. And that would be our conclusion for this particular patient. So this is just to show the same patient, a zoomed view of the mitral valve. You see one leaflet moving, the other one is not seem to be moving. So this is a stuck bileaflet valve versus the previous first patient that we saw, which is a normal single leaflet valve. You notice how this leaflet is attached here. It has a large orifice here. It is attached here eccentrically and it has a nice excursion. Whereas this seems to be somewhere in the middle with no attachment to the side, as you can see. The other one also should have come like this here, parallel, kind of parallel to this one which is moving, but that is not the case. So we can see that this is not attached to the side. So that way we can make out that this is a bileaflet where one is stuck versus this is a single leaflet and that is moving well. The other thing that you can notice also is that this is a fairly large kind of leaflet or disc, which almost kind of fills the whole annulus. Whereas this, it's a little smaller in comparison. And you can imagine that it's probably two doors within one frame, which is trying to open and close. And out of that, one is already closed and the other one is opening. So this is a single door that you are seeing, which is opening and closing very well. These are two doors, out of which two doors in one frame, out of which one is moving well and the other one is not seem to be moving well. And this, not only this is substantiated by increased turbulence and high gradients and all the other parameters that we just demonstrated. So this is the fluoroscopy which was done for this patient. So whenever we are in doubt or we need confirmation. So as you can see, these are the discs that we see in two views. You can see only one of the discs moving both the views. That is this one and this one. The other disc is not moving. So then we are able to kind of conclude that this is a case of a stuck valve where one is not moving. This patient underwent thrombolysis. But even after thrombolysis, the valve continues to remain the same. Gradients are the same. We see only one moving. Patient otherwise is not very, greatly distressed or in much discomfort. But certainly one of the discs is not moving. And so then this patient, thrombolysis has not worked, and hence this patient would need something more than that. So most likely repeat surgery. And this is a modified kind of short axis view, which I will also continue to show through today's cases. And next time you get a bileaflet valve, you try to get something like this. Wherein you can get rid of the shadowing, not the typical short axis view, but a slightly modified short axis view going to two-chamber view. It's a very modified, unorthodox kind of view, which we may use to see both the leaflets and both the discs. So here also we see only one of the discs that is moving. We'll see other cases where we can demonstrate both the leaflets or both the discs moving. So remember, if it's a bileaflet valve, try to use this particular view, the modified short axis to two-chamber view, to help you see the different discs. This is the next case, a 41-year-old male. MVR was done in 2019 October, not very long ago. He had a stuck valve in January of this year, and he has been on adequate oral anticoagulation. Now also he came for a routine OPD visit and was doing quite well. He didn't have many symptoms. So this is again a bileaflet valve. And as you can see, we are not able to see much disc motion. Turbulence across the valve is seen. This is the two-chamber view that we are seeing, and these are the two discs that we are seeing. Again, you are seeing both the discs in the form of a V, and you can see that there is hardly any motion of the disc. However, we are not able to see any clear mass or at least a large mass or anything of that sort. We see this is the continuous wave Doppler across the valve, and you can see this typical shape. So just keep this shape in mind. So this is what I have been saying. When the pressure half time is grossly increased, you see that the DVI is also grossly increased. Peak velocity is markedly increased. Mean gradient is definitely more than 10. Very elevated gradients, a lot of turbulence across that valve. You hardly saw any disc motion. And your VTI, LVOT VTI is also low. So meaning to say there is hardly any antegrade flow across the valve, and the forward flow is also reduced across the LVOT. And so that there is no doubt about the obstruction in this particular patient. So he already is a patient who has been thrombolized about 3 months after surgery on adequate anticoagulation. Once again, now he's had a problem. Let's just calculate the effective orifice area. Let's say his LVOT diameter is 20 millimeters or 2 centimeters. We have all the other readings here. LVOT VTI of this much, so LVOT stroke volume of 21 ml. Mitral VTI we know is this much. So a prosthetic mitral effective orifice area is the LVOT stroke volume, which is 21 ml divided by 69.5. And that is markedly reduced effective orifice area. So that is just to kind of remind us of things, of how we arrive at effective orifice area. Just as a reminder, 3 things are always required That would be LVOT stroke volume, that is LVOT VTI and LVOT diameter, and your mitral VTI. So then, yeah, so you can see marked turbulence across the valve. This is the 3-chamber view. He's got a high TR velocity, and pH is also there because this is his early diastolic PR velocity. That is also more than 25. And this is the shape of the Doppler jet. So all these things put together, there is no doubt he has pulmonary hypertension. And this is a prosthetic valve obstruction. So all of these fit in the last category here, and that suggests significant stenosis. So even this particular algorithm, if we say that, now compare this with the aortic picture that I showed you the last time, the shape of the jet or the acceleration time comes here. Acceleration time or the shape of the jet, and then you decide. So likewise, you can use the same approach or a similar approach for the mitral valve also. And what you can see here is that the pressure half time is increased, the mean gradient is increased. So this is pathological. DVI is grossly increased, velocity is increased. All those parameters are increased, and this is prosthetic valve obstruction. Now this patient underwent thrombolysis. So the previous patient I showed you was somebody who had an obstruction, underwent thrombolysis. There was no change, was sent for an MVR. This patient, you can see this is a slightly off-axis parasternal long-axis view. And you can see that the disc is nicely moving. The flow has become better in terms of it is definitely much more laminar than what we saw earlier. And this is again a 3-chamber view. You can see this is the multiplane, which is showing the kind of the 2-chamber view or the short axis 2-chamber view hybrid kind of view, which we are seeing this side. And you can see both the discs or both the leaflets are nicely moving. And you can see here, likewise, that the turbulence has markedly reduced. So this is a normally functioning valve now. We will substantiate that by, now notice how the shape of the jet has also changed. This has become markedly steep, and the gradient is now only 5. Pressure half time is also reduced. So this is all immediately after the thrombolysis. So peak velocity from 2.5 plus has come down to 1.3. Mean gradient from 16 is down to 5. DVI from 3 point something has come down to 1.6. Pressure half time also nearing 200 has come to 60. The aortic forward flow or the LVOT forward flow also has increased remarkably. It's normalized now. Once again, it was repeated pre-discharge. Since this person already had thrombosis twice, it was repeated again. And again, you see that things are fine. Again, you can see that the mean gradient is 2. It's a nice steep slope. LVOT flow is good. The pulmonary acceleration time is also over 100. All these things point us to the fact that the obstruction has been satisfactorily and relieved. So this would be. So this is the view that I was generally talking about. This is a zoomed view. As you can see, these two discs are nicely moving. And what you can see also is fairly laminar flow as compared to the markedly turbulent flow that we saw a while ago. So this was how it was initially in this particular patient, a similar view, 2-chamber short axis kind of view. What you can see is that initially these discs were not moving at all. And subsequently after thrombolysis, you can see that the discs are moving nicely. So not only Doppler, not only color, even looking at the valve in 2D is extremely important. And many of these things, much of this information is you can easily get from a routine transthoracic echo itself. And especially for those who have bileaflet valves, this is a view that I would say is possible in maybe 8 out of 10 patients. So it is something definitely worth trying to get to try to see both the leaflets. So that is something to just bear in mind. And so once again, these are the different parameters. It had all normalized in this particular patient. Velocity had come down, gradient had come down to 2, VTI, the DVI had come down, it was around 1.6. Pressure half time also was 60, 80 in that range. So everything had completely normalized. So just to kind of re-emphasize, so this was for the aortic valve. We made a distinction between a triangular jet and a rounded jet. So pattern recognition helps in echo also. So this was somebody who had an aortic stenosis with a nice rounded contour. This is a patient I showed last time. We can do the same for the mitral also. So wherein this was the pattern which was seen initially with a very flat slope, and then it becomes a steep slope. In the gradients, everything comes down post thrombolysis. So just storing these images in mind and trying to be alert if we do find it is extremely important. The next case is a 56-year-old male. He had a TAVI in 2019. So this is just to highlight the importance of looking for thrombus and bioprosthetic valve thrombus. This is an aortic valve actually. It's a TAVI patient that I just showed just for the sake of understanding. So he also had valve thrombolysis and was thrombolized a couple of times. So first time he came, he was non-compliant, and this was the CT which was done. Also the importance of CT for bioprosthetic valve thrombosis, not only for the mitral, but also not only for the aortic or TAVI, but also for other bioprosthetic valves. So this was a thrombus that was seen in his first presentation. He came last month, and when he came, things pretty much looked, he was asymptomatic, and everything more or less looked okay. But findings like this, we said last time, should not be ignored. Everything doesn't look very clean inside this aortic valve. So this is the stent on the side, and these are the bioprosthetic valve leaflets. So everything doesn't look very clean. There's a bit of turbulence, a bit of shaggy appearance. So that should not be ignored, especially since given his history of previous valve thrombosis. And his valve gradient was 28. And just based on this, he was sent for a CT, and he was found to have thrombus. Again, he was thrombolized. And this was the appearance post thrombolysis. You can see nice thin leaflets. Gradient has come down to 12, and the thrombus has also disappeared. Now, just applying the same thing. The reason I am tying this to last time's thing is to kind of try to connect and develop a certain kind of pattern in our understanding of the disease, not thinking that this is different from the aortic. So this is the next case where we have a 57-year-old male. He has 27 mm St. Jude epic, and he's had a tricuspid annuloplastic ring also. 3 years later, presents with severe dyspnea, hypoxia, and shock. There is no fever. Blood cultures are negative. Now, this is not our case. There are few cases which are not ours. Most of the cases are ours from our institution. So as you can see, this is like a 3-chamber view, and you can see a turbulent flow across the mitral valve. But the details are not very clear. So this is the 4-chamber view, 0 degrees. So this is the LA on top. This is the mitral valve. This is the LV, the RA here, and the RV here, and that is the tricuspid valve. So as you can see, it is a markedly thickened mitral valve leaflets with very restricted mobility. And this mass also, there seems to be some mass which seems to be kind of layered along the wall of the left atrium also. So this seems to be extending all the way like this. And his gradient also was high. Mean gradient was 20. This patient was thrombolized, and the same image, 0 degrees, you can see post thrombolysis about how all that clot has disappeared. It has become nice and thin. And this is the transthoracic echo. also back again. So this is also something to bear in mind. Somebody without all this history also, with just a normal bioprosthetic valve in the mitral position comes for evaluation, we might get this appearance for a stented bioprosthesis. And these are the leaflets inside, which are fairly thin, and you can see the mobility also. So we are supposed to see how thick the leaflets are, whether there is any mass that you can appreciate, what is the mobility of those leaflets, whether there are any other clots, is the patient in AF, what is the LV function like. All these things we kind of assess when we are assessing a bioprosthetic valve. And this is just to show pre and post thrombolysis, not very great 3D images, but here you can see the clot over the mitral valve. This is looking at it from top, that is from the left atrial aspect. You can see that the clot here, and here it has disappeared. Of course, you can see a lot of dropouts also. So how to identify bioprosthetic valve thrombosis, BPVT, bioprosthetic valve thrombosis? It's extremely important to carefully monitor the gradients over time. So this is extremely important. So we should not disregard any minor increase in gradient also. If we don't have a satisfactory explanation, then these patients should be under careful follow-up and close follow-up. So that is something to know about bioprosthetic valves. That is the point I'm trying to make by showing these examples. So if there is a greater than 50% increase in mean gradient over post-implant values, be it aortic or mitral or any position, if there's an increase in gradient, even if the patient is asymptomatic, that is something to keep in mind and something to monitor carefully. Then, of course, like I said, you look at the cusp thickness, you look for any thrombus, which may be layered. You look at the cusp mobility. Is the patient in AF? Is the patient on anticoagulation at all? Is the first question. And if so, what is the INR like? And T may be recommended in those with abnormal findings, like in the case that we just saw. In the previous TAVI case I showed you, even CT may be useful. So TCT and TE is extremely useful for bioprosthetic valve thrombosis. Just a slight point to note, for bioprosthetic valve thrombosis in the aortic position, many times TE may not be very useful. So hence, like we saw in our case, the patient directly went for a CT. Whereas in the mitral position, like we saw in the case that we just showed, transesophageal echo may be quite useful. So according to the guidelines, the duration of anticoagulation may range from 3 to 6 months or something. But this is evidence to show that the maximum number of cases of bioprosthetic valve thrombosis happen between 13 to 24 months. So the point here is that even in bioprosthetic valves, there may be a role for continuing long-term anticoagulation. So that is the message that we see from the cases that we have just illustrated. So this is from different the guidelines. And you can see the different valves, and this is all freely available. We can go through it at our leisure. But even in bioprosthetic valve, it says about 3 to 6 months, and first 6 months, the recommendations. Transcatheter valves also likewise. But evidence has shown that the bioprosthetic valve thrombosis can be seen later also. The next case is a 55-year-old female mitral valve replacement 3 years ago with a 26 mm carbomedics valve, which is a bileaflet valve. Non-compliance with warfarin. Patient had dyspnea, orthopnea, and fatigue since 5 days. This is also not our case, but just to show you a very interesting, this bileaflet valve, you can see one leaflet or one disc which is moving, and you can also see this kind of soft mass here, which is probably not allowing this leaflet to open and close properly. This patient was thrombolized, and this is the image post thrombolysis. Again, you can see that this is a bileaflet valve. Both the leaflets are seen. You can see the nice radio opaque ring, and within that you can see the leaflets also, which are quite nicely radio opaque, and you can see the disc motion also post thrombolysis. So this patient also has completely recovered with thrombolysis. I had shown this picture last time, this table. This is from the EACVI 2017 guidelines for prosthetic valves. And as you can see, the point here is to just show the opening and closing angles of the various prosthetic valves. So as you can see, this patient had a carbomedics valve, and his opening angle was definitely over around 80. So he had recovered post thrombolysis. So this is something to note, that on fluoroscopy also, this opening and closing angle is something which is possible to look at. So coming to another, so this patient had thrombus, and now the other thing is pannus. So pannus is something like scar tissue, which develops over time. It's a gradual process which happens over a long period of time, and the impact of it also will be greater if the orifice is smaller. Or sometimes pannus can grow into the opening closing mechanism, and then there may be a problem even if there is not much pannus. So that is the other thing to keep in mind. So it usually correlates with the duration of the valve, whereas thrombus usually correlates more with anticoagulation and anticoagulation status. So as you can see, this pannus usually grows in from the sides like this, whereas thrombus generally can occur anywhere and usually can happen in the middle like this. And as you can see in the sides, there is no extra tissue material which has grown. So that is a table just to kind of reiterate what I have just said. So as you can notice here, the CT also can be used to distinguish thrombus and pannus. So the attenuation value, or something which is more radio opaque, will have a higher value. So pannus in that sense has a higher value as compared to thrombus. So that is also something which can be used to distinguish thrombus from pannus. Now, when we find this thrombus, should the patient go for surgery or fibrinolysis, or that is thrombolysis? So the no need to remember many big things, but the simple thing is, if it is a small clot, less than 0.8 centimeters square on TE, then we can proceed with fibrinolysis. Whereas if it's a very large clot, then the patient may need to go in for a surgery. So this is just an algorithm from the valve update guidelines. So T is used mainly to look for the thrombus size and accordingly decide whether fibrinolysis or not. The next case is a 54-year-old female, MBR done 4 years ago, with a 29 mm St. Jude's Regent, past history of CVA and antiphospholipid antibody syndrome. And this was from a recent case report which I found online. And it was interesting because the patient had proper PT-INR values, but the patient was under anticoagulated. And the theory was that it was because of this antiphospholipid cross-reactivity with the PT reagent. And so that is something to bear in mind. So that is what the case was. Again, 3D showing both the discs. It's a bileaflet mechanical valve. Both the discs are moving nicely, but you can see these multiple filamentous kind of structures which are moving in different directions. And the differential diagnosis of this would be thrombus or pannus or vegetation, or even non-bacterial thrombotic endocarditis because the patient had antiphospholipid antibody syndrome. So all these are possibilities, but what was most likely after all extensive evaluation was thrombus. So the patient was again anticoagulated properly, and this was all those strands kind of thing went away, and everything normalized. So the important thing that I would like to highlight here is many times, whether it is thrombus, whether it is vegetation, whether it is non-infective or non-bacterial, whether it is a panels, all these things may not be as straightforward. Many other things need to be taken into consideration: the history, the other investigations, blood cultures, everything needs to be taken into account to finally arrive at a conclusion as to what it might be. So this is basically the study from which we kind of arrived that those with thrombus area less than 0.8, their risk of death and complications was less as compared to those with thrombus area of greater than 0.8. So that is basically the impact of the size on outcome. So if you have a very large thrombus, they might do better with surgery as compared to thrombolysis. However, patients' willingness, finances, all those things, practical things need to be taken into account before taking decisions. So this is again not our case, but just to illustrate another concept, wherein you see that both the discs are fine. There is no problem with the disc. The manufacturer's EOA is for this particular valve size comes to be this much. That is 1.35 plus minus 0.17 centimeter square. And the measured EOA is 1.35 centimeter square, which means there is not much difference between what we measured and what was said to be the EOA for that particular valve. So every valve has a particular EOA which the valve is supposed to have. That is the effective orifice area. Now, what is measured is almost the same as that, which means there is nothing really wrong with the valve. But what is the problem? The problem is the patient's body surface area is 2.01, which means his indexed effective orifice area is only 0.67, which is markedly a small valve. So this is extreme patient prosthesis mismatch. So that is those are the numbers to keep in mind. Anything less than 1.2 is moderate, and anything less than 0.9 is severe. So that is just to kind of show the same thing. More than 1.2 is mild, less than 0.9 is moderate, and sorry, 0.9 to 1.2 is moderate, and anything less than 0.9 centimeter square per meter square body surface area is severe patient prosthesis mismatch. As we saw last time for the aortic valve also, with body mass index being greater, the numbers are also different. So that is something to bear in mind. So this is not just an infinite reality. For body mass index greater than 30, the numbers are a little different. So that is patient prosthesis mismatch, as we see here. So what are the consequences? The consequences are that the patient can have persistent pulmonary hypertension. His exercise tolerance also may be poor. The reason for which it was operated, especially if it was mitral stenosis or something, he may continue to have the same symptoms because even now the valve is functionally stenotic and is small for the patient size. And hence, in the long term, the patient may not do very well. So that has been also shown by evidence that those with severe patient prosthesis mismatch don't do as well as normal or non-significant PPM. So how can we avoid this? So this is something that we kind of saw last time. So what we do first is to calculate the patient's body surface area based on height and weight. So that is the first step. So any patient coming for a valve replacement to the echo lab for assessment, first thing we do is body surface area by height and weight. So once we have the body surface area, we have these values. For the aortic valve, 0.85. For the mitral valve, it should be at least 1.2 centimeter square per meter square, which means it is 1.2 times the body surface area. And that should be the minimum valve area of the prosthetic valve that the patient will get. So that is something to bear in mind. So Otherwise, if we just without knowing the size, go ahead, then patients can have. Though it is a less common in the mitral valve position because the annulus is bigger as compared to aortic valve, it is still something to be borne, especially in small built people or younger individuals, something to keep in mind. And so these, I just mentioned that these kind of charts are available for different valves. So we can then see for a given valve, what is the effective orifice area, and whether what we have calculated as the correct valve area for a given patient will apply or will be good for the given patient. So that is how these kind of charts will also help us choose what is the effective orifice area and what would be the proper valve for the given patient. The next one is a 26-year-old male, mitral valve replacement in, again, last year, 31 mm TTK Chitra valve, which is a single leaflet tilting disc valve, which was a patient had infective endocarditis prior to that. He was found to have a paravalvular leak. I've already told you what the problem is. But these are the images. So this is all pre-discharge, that is after surgery. So as you can see here, you can see these bubbles or kind of opacities. So these are normally seen in prosthetic valves. And if it is seen, then that is a good sign. That means that the valve is functioning well. And I say that because sometimes when the valve becomes obstructed because of thrombus or something like that, then these bubbles also disappear. Just as valve clicks also disappear, these micro bubbles or micro cavitations, as they are called, they also disappear. And they re-emerge after thrombolysis. So this reappearance of micro bubbles after thrombolysis in somebody who has had a stuck valve is also sometimes taken as an indirect sign of successful thrombolysis. So that is something to just remember. Back to this patient. So this is the, you can see a single leaflet tilting disc valve, which is nicely moving in all views, hardly any turbulence. Everything looks good. Even in the 4-chamber view, we don't see much. These are the gradients. So the gradients are shown here. So you have a DVI of 2.2. The peak velocity is also slightly on the higher side. Mean gradient is 6.5. Pressure half time is 72 milliseconds. So these are the values for this given patient. But what you can notice here is that the pressure half time is very steep. So pressure half time is 72. Here also, this also was around the same time. This was immediate post-op, and this also in the same hospitalization was repeated again. As you can see, mild increase in the gradient as compared to this particular study. And that is also because the heart rate is a little higher than this one. And however, the slope doesn't change. The pressure half time, the steepness of the slope remains the same. So that is something to bear in mind. This is the LVOT Doppler. So these are the parameters, 2 of them in the normal range and 2 of them in something like possible stenosis, slightly raised. So so how did we come to this? This patient had a regurgitation, and that I'll just tell you. So the VTI was 2.25, which is elevated. Pressure half time, however, is less than 130. So that is why we don't go down this path. We go down this path, wherein you have a slightly high gradient, you have a slightly high velocity, you have, but the key thing is that the pressure half time is less than 130. So that is the most important thing that we find in this particular patient. So why am I going on and on about this pressure half time? And that is because there is evidence to that. So in somebody with high gradients like this, what you can see on this side is that those with a pressure half time of more than 130, all of them were stenotic, whereas less than pressure half time less than 130, the chances of it being obstructive is extremely small. Many of them were regurgitant. So if you have a high VTI, high gradient, high E-wave velocity, high VTI, high gradient, high DVI, and it is likely to be regurgitant, especially if the pressure half time is less than 130. Whereas if the pressure half time is greater than 130, then it is likely to be obstructive. So that is the key message that I would like to kind of share through this. So again, so when you see an abnormality in the gradient like that, carefully interrogate in modified views, in unconventional views also. And what you can see here is the paravalvular leak. Many times there will be a lot of shadowing here in the left atrium, and it may be very difficult to see. So for that reason, first of all, you do all the technical things. The technical things meaning optimize the image, you reduce the depth, you zoom the area of interest, you put the color box properly. You reduce the gain also. If you have your 2D gain is very high, many times these things may be hard to appreciate. So reduce the 2D gain, and then you can see here in the medial aspect, you can see flow convergence also. So this flow convergence is also important where my marker is. That means that this is significant, that this is not just some small regurgitation. There is already flow convergence that is seen here at the normal Nyquist limit, and hence this is significant. This is just to show in orthogonal views the same thing. This is something good to know because this is very useful when we do paravalvular mitral valve leak closures. So this is how it appears. This is called a surgeon's view. This is the mitral valve. And this is looking at the mitral valve from the left atrial aspect. So generally this we get from the transesophageal echo, this particular view. When we do a 3D, we will get this particular view. I'll just give some illustrations. So on this side, you have the left atrial appendage. This side, you have the interventricular septum, that is medial, and the tricuspid valve would come somewhere there. And then we need to see, then you have a clock phase. Aortic valve is always positioned at 12 o'clock. So then in relation to these landmarks, wherein you have the appendage here, you have the aortic valve here, you have the anterolateral commissure here and the posteromedial commissure here. And then you are looking at it from the left atrial aspect. Then you try to see where in the clock phase is the leak. So that is something which is quite easy to do with a transesophageal echo or a 3D en-face view. But even in transthoracic view, we can attempt to do that by taking many things into consideration. So for example, transthoracically, we are looking from the LV aspect. Here we are looking from the LA aspect, which means we are looking from the top as far as this picture is concerned. Now, if we look from the bottom, this is how it will look. So what you can see here is the regurgitation, which is coming close to the posteromedially. So the posteromedial commissure would be here, anterolateral commissure is here, and this is posteromedial. So this is posteromedially. And how can I confirm that it is posterior? I can see this jet which is coming posteriorly. So it is not anteriorly, it is going posteriorly. So by this, I can say that it is coming from this somewhere in this particular sector. It is posterior, it is medial. So somewhere in this particular region would be my thing. I can get more details by taking more views. I would come very close to where the leak is likely to be. But this can be possible when we kind of carefully interrogate the full annulus using unconventional and modified views, and then certainly by doing a TE, and definitely by doing a 3D TE also. So just to help us understand, so we have this mitral, again, looking at it from the top, the mitral valve, looking at it from the LA. So you have this, green is the 2-chamber view plane. This is the long axis view plane, which is the parasternal long axis or the apical long axis view. And this would be the 4-chamber plane. So combining all these things. So when we are saying posteromedial, it would be somewhere in this particular area. So that is where our leak is likely to be in this given patient. So this is again an illustration from one of the articles that I found. This is something that this is how we do it. Also, this is during the paravalvular leak closure by device in the cath lab. So you can see the wire, you can see the catheter through the defect, and then you can see that there are 2 devices that have been put here in this particular position. So the TE and 3D TE also helps guide the paravalvular leak closure and also localization. So this also would be something like a posteromedial defect, something similar to what we saw in our patient. So this is also in the 3 o'clock to 6 o'clock range. And if you want to be more precise, this is exactly around 4 o'clock position. So what is the problem with this hole? Grossly to remember, a small hole will generally cause hemolysis. The patient can have hemolysis, that is destruction of the RBCs, and all features related to that. Patient may be anemic, and blood markers also will be deranged pertaining to hemolysis. If it's a large hole, then the patient can have dyspnea and heart failure as a result of that. That is just to remember. Now, so when you have a prosthetic mitral valve regurgitation, this is again not to bore you or not to intimidate you, because this is all well known to most of us who are assessing regurgitations. But specifically for paravalvular leak, prosthetic valves, almost everything is similar to native valves, except for this circumferential extent of paravalvular regurgitation. So in the short axis view that I just showed, be it 3D or whatever view, in the en-face view, if we can see that the regurgitation is less than 10%, then that is mild. If it is greater than or equal to 30%, that becomes severe. So in addition to other standard parameters that we use for assessment of mitral regurgitation, this is one additional thing that we need to bear in mind while assessing prosthetic mitral valves. So this is just to reiterate, high velocity, high gradient, increased DBI, but a short pressure half time. Think of a prosthetic valve regurgitation. So what is the important thing? So a patient with a prosthetic valve with nice disc motion, but a high gradient, there is no reason he's not anemic or anything of that sort. We might be missing a prosthetic valve regurgitation. Hence, it is very important to carefully interrogate the 360 degrees around the annulus through modified views in a very slow, systematic manner to pick up any. And if there is doubt, then to definitely do a transesophageal echo. This is the next case, is a 51-year-old female. Again, this is a bileaflet valve, bileaflet mechanical valve done last year. Again, you can see the disc motion. This is the slightly modified 2-chamber short axis where you can see the discs moving. This is the same parasternal long axis view with color compare. And what you can see here is this leak here. Now, this leak is more anterior. The other leak we saw posterior, whereas this leak is anterior. So that is something which is which we come to know by this view. And the other thing also, this is a 4-chamber view. What we can see is the leak is also medial. So as opposed to the previous view, a previous patient where the defect was posteromedial, this defect is likely to be anteromedial. So we can clearly see how this is different from the physiological regurgitation that I talked initially about. So these jets generally are eccentric. They come from one side of the annulus, and they don't look like anything like the normal jets that we see, which come from within the valve. These don't travel very far. They are generally narrow and short as compared to paravalvular leak that we just talked about. So this is just a table to show the same thing. Again, like I showed you, proximal flow acceleration or flow convergence, that is definitely pathological. And then other features of severity of mitral regurgitation may be there. Pulmonary hypertension, TR gradient, all those things may be elevated. Generally, it may fall, it's asymmetric. It comes from an eccentric location. So that is how it is different from a normal regurgitation. So again, in this particular patient, it is anterior and it is medial, and hence it would be in this particular, somewhere in this particular region. So all this is important to know beforehand itself, exactly where it is, so that the intervention can be done properly. Now, we can also see the effect of tachycardia in this particular patient, about how high the gradient goes. The velocity is high, mean gradient is 21 dVi, so there is significant regurgitation. This is what I mean. But pressure half time, this is a very steep slope. And you can see that the LVOT VTI, that is forward flow, is also compromised, which means forward flow across the LVOT is reduced, meaning much of the flow is happening backward into the LA, which means that the regurgitation is also significant. That is what we are seeing in this particular patient. So by looking at this, just by seeing a gradient of 21, we should not immediately say there is prosthetic valve obstruction. We should make an attempt on echo to see what the movement of the disc is like. What is the VTI? What is the DVI? What is the mean gradient? What is the pressure half time, most importantly? And then we can see, if we see pressure half time like this, then we should think in terms of regurgitation, actively look for it, and maybe take help of this also, disc fluoroscopy. So the importance of fluoroscopy. So here, again, the importance of doing a proper fluoroscopy. So especially if the suspicion of regurgitation is high, we have demonstrated that on echo also. We are seeing that the discs are quite well seen. We want to be very sure. We are doing this, but then we get a view like this, where we are seeing one disc moving and one not moving. Is it an obstruction? So that is the whole importance of taking proper views also, even on fluoroscopy, before concluding that there is no obstruction or that the valve is fine. So if you show this particular image, then you can wrongly conclude that obstruction is the cause of the high gradient. And hence the importance of even doing a simple fluoroscopy and doing it properly so that you are able to see the disc clearly. So this again is a patient with a pathological regurgitation, mainly because everything else is like obstruction, gradient high, VTI, DVI high, everything is like obstruction. Only thing that kind of separates is the pressure half time. So even if this is the single message for today, I think my job is done. So to look at pressure half time to kind of separate regurgitation from other lesions. And what you can see here is also that CT can be used. The point, this is again from literature, to show the defect and the paravalvular leak. So we can use TE, we can use CT, we can use information like fluoroscopy to say that the valve is okay, and hence the gradient of what we are seeing is not related to obstruction. All that we can be, we always need to put multiple things together to finally come to a conclusion. Now, this is extremely important. It's not very rare to see this phenomenon, but I will definitely admit that in the earlier days, I have also done TE unnecessarily for this particular phenomenon, just because there was a doubt that there was a mitral regurgitation. So this is something to bear in mind. A pseudo regurgitation, which is because of flow in the LVOT that is captured, and you may see it in the form of color like this in the LA. So that is something to bear in mind and be cognizant of. Pseudo regurgitation is something that can be seen with prosthetic mitral valves. The next is 40-year-old male with MVR tricuspid ring annuloplasty in 2019, again last year. TTK Chitra valve 29 mm. He is on dialysis. He's on CK. He has CKD. He's had a stroke in the past. He actually was admitted with a stroke, and in hospital only they found that he had some fever also, and blood cultures grew coagulase negative staph. So these are his images. So it's a single leaflet tilting disc Chitra valve, and you can see this mobile mass with independent mobility. It's a fairly large mass that you are seeing, and you are seeing some color flow turbulence also. Most likely that is the reason why he's had the stroke. The gradient is also slightly elevated, peak velocity a little high, some amount of obstruction also as a result of this. DVI is also 2.9. Some amount of obstruction, TR gradient is also a little high. Not just that, he also has, his TR is quite significant. His IVC is dilated. And what you can see here is systolic hepatic vein flow reversal, as has been shown in this particular picture, suggesting severe tricuspid regurgitation. Not great views, but we can say that the leaflets are fairly okay. And it's most likely because of annular dilatation. TE was done in this particular patient, and what you can see, this is the 0-degree view. The disc is nicely moving, a single leaflet tilting disc valve, and you can see this particular mobile mass, which is kind of prolapsing into the LV in diastole. And you can see the flow turbulence across the mitral valve. You can see this particular mass here, and the same thing is seen in multiple views. TR also to show in different views that it is significant. Just this algorithm on the importance of TE in prosthetic valves. So these are all the different conditions where we might need to do a TE, like we did in this particular case, prosthetic valve with some fever, staph aureus. It could be nosocomial, especially if there is no known source, then that is something. So any prosthetic material, fever, any intracardiac lead, or we are not able to get enough information from transthoracic echo, then we can do a TE. And we also saw how for paravalvular infection, cardiac CT is extremely useful. The next one, I think I should wind up soon. Just give me 5 minutes and I'll finish. So the next one is a 59-year-old female. MVR was done in 2006. This is a Starr-Edwards valve, and he's he's also had a tricuspid annuloplasty. Comes with worsening anemia, worsening dyspnea. He has anemia, and he's also a smoker. So a gradual worsening of dyspnea. Starr-Edwards valve done long time ago, and tricuspid annuloplasty. Most likely that would have been a suture annuloplasty without a ring. So you can see this double atrial shadow, and you can see the prosthetic Starr-Edwards mitral valve, huge cardiomegaly that is seen. And the same thing is seen in X-ray. The prosthetic mitral valve motion is seen nicely. A huge left atrial enlargement, left ventricle is quite small, the parasternal long axis view here. And the same thing here, right atrium and left atrium are hugely dilated. You can see that the poppet motion is quite okay. And this is the flow across the mitral valve, which seems to be okay. But the main problem is that he has significant tricuspid regurgitation. So though an annuloplasty was done previously, the leaflets also look fairly thin and not diseased, meaning it's unlikely to be organic. Yet he has severe TR, and most likely he's got a plethoric IVC, dilated right atrium, and most likely that is the reason why he is symptomatic. So this is the importance of doing a proper TR assessment, not only TR, the tricuspid annulus also. These are two things, the severity of TR and the tricuspid annulus measurement is extremely important in any mitral case, pre-operatively and also for follow-up, because this is the impact. As TR increases, the survival also reduces. So that is what we are beginning to understand, or we understand these days. And hence, whether it is for BMV or whatever the procedure might be, especially if it involves a mitral valve, to pay adequate attention to the tricuspid valve and also try to measure the annulus carefully. The next one is a 49-year-old female, MVR done in 2012. This is a bioprosthetic valve that this patient has. So this is the bioprosthetic valve. This is a stented bioprosthetic. So notice how this patient has this appearance of a crown. So this appearance of a crown, that is from the stented bioprosthesis. So the purpose of putting this X-rays is to just kind of also tell us how it appears on the X-ray. So this, you can see some regurgitation that is seen in the zoomed parasternal long axis view. And you can see marked flow turbulence across the mitral valve and the thickened leaflets with markedly restricted mobility. So this bioprosthetic valve with thickened leaflets, markedly restricted mobility, all this with increased color flow turbulence and also high gradient is something that we also saw in the context of bioprosthetic valve thrombosis. So that is also something to keep in mind when we assess these patients. So this is how the valve normally would look in the mitral position, in the aortic position, and these are the different images that are seen. This is in 3D, and this is in the short axis view. So so this patient most likely would have a structural valve deterioration. He has got regurgitation also. We don't see any obvious mass or anything like that. We see that structural valve deterioration in the mitral position begins to happen after 5 to 6 years after replacement. So that is the important take home, that these valves have a life, and beyond that point they start degenerating. And that may manifest as thickened valves, restricted mobility, regurgitation, and that is what it is. So we saw a case of bioprosthetic valve thrombosis earlier, and now a structural valve deterioration. And as in the first case, from evidence from this particular study, when you see a mean gradient increase on follow-up, when there is an increased cusp thickness, abnormal cusp mobility, subtherapeutic INR especially, and paroxysmal AF, all these things point towards bioprosthetic valve thrombosis as opposed to a structural valve degeneration. This is a 48-year-old female, MVR done in 2011, and this is a St. Jude's bileaflet valve. Comes with the dyspnea on exertion class 2. So again, St. Jude's, you can hardly see the valve. As you can see here, this valve is hardly seen as compared to the other valves that I just showed you. So this patient, I mean, I don't have the pre-thrombolysis images, but the patient had severe LV dysfunction. And this is immediately in the same hospitalization post-thrombolysis. So this is something that we noticed in this particular patient, wherein you can see marked LV dysfunction. You can see again that these two discs are nicely moving, and there is no color flow turbulence. And 3 months after the discharge, the LV function seems to have improved even more. So this is something just to wonder whether if there's an acute reduction in LV filling, whether there is any LV dysfunction that might happen as a result of it. LV dysfunction has been noted even in underfilled conditions like severe mitral stenosis, or even in TOF with severe pulmonary regurgitation. One of the mechanisms there for LV dysfunction has said to be the decreased preload. So whether abrupt reduction in the preload is what has caused this and caused it to recover also over time. This is probably the final one. 29-year-old female, 29-year-old male, MVR done in 1994 with dyspnea and pedal edema for 3 months. He's had coronaries, everything done, and that is it. So he comes with dyspnea, and that is the Star Edwards valve, which was implanted in 1994. You can see it of the ball and cage nicely. So how do we recognize it? I said you take this right cardiophrenic angle and left hilum, and if it is below this line, it is likely to be mitral. Above that, it is aortic. It's not as simple and as straightforward as that, but suffices for now just to know this basic thing. So this is the patient's echo. This is the 4-chamber view. You see some turbulent flow in that color box sector. And this is what we have kind of traced. Velocities appear to be quite high. Gradient is also high. The mean gradient is 21. And the TR velocity is high, though it is kind of a little overestimated. Maybe it's around 3.5 meters or so. And this was the patient's, the patient underwent an angio and underwent, and this is the fluoroscopy during the same time when the angio was being done. You can see the nice poppet motion inside the cage. So this is essentially a normal valve. So what was the problem? So subsequently, the shape kind of remains the same, but the gradient is not as high as it was before. So the gradient is around 9. So if we go back, this patient looked like he had some aortic regurgitation also. So that is something to bear in mind, that you should not trace both the diastolic flows, aortic regurgitation as well as the mitral inflow, and should not confuse the mitral inflow for aortic regurgitation and wrongly make an assessment of prosthetic valve obstruction. So this is the final slide that I leave you all with. This is from the ASC 2009 guidelines for prosthetic valves. The main thing, or the key thing, or the point of emphasis, all this is they're widely used in literature. The main point of emphasis is that the pressure half time is something that should be definitely taken into account, and if it is markedly increased, generally would point to a significant stenosis. Thank you all. Thanks for your attention.
Thank you so much, sir. It's again a wonderful session that, as always, that you do. So your presentation, I think, I must say that this looks like an atlas of the prosthetic assessment of mitral valve. So it's a very much in detail and very informative. Thank you so much, sir. Today, I think in the chat box, we see, tons of compliments and comments, rather the questions that, and most of the audience, already present in the webinar are expecting that we must retelecast this, and definitely we are going to retelecast all the past webinars from the many speakers. We have got the approval also. We will definitely give you details of that, where we will get the links and how you can actually watch them again. Very soon you will get the updates on that front. So keeping the time in a sense that, I think I'd like to take a couple of questions, sir. Is that okay, sir?
Yeah.
Sir, I think since in the beginning you mentioned that, this is absolutely for the mainly focused for the beginners who want to do the echo,
Yes.
prosthetic assessment and all that. So
Yeah.
what's your tips and tricks for the how to do an echocardiography immediately after the post-surgery, valvular surgery especially?
Yeah. So this is one thing where practical limitations and all those things also come into the picture. Ideally, the recommendation would be to do it 4 to 6 weeks after the surgery, to kind of once the hemodynamics, once anemia, once the bandages, everything is off, and that would be the best ideal situation. So when it is possible to do that, we should do that. But a center like ours, where most of the patients come from far off places, many of them from outside the country, we generally do the first assessment soon after the surgery. I mean, not soon after, it is pre-discharge. So somewhere would be around the 7th to 10th day or so. And then after that, whenever they come for follow-up, which may be after 3 months or 6 months. So that is not ideal, but that is a limitation. But if it is possible, then 1 month after the surgery would be a good time, when the patient also may be more cooperative. He will be in less pain, and especially if if somebody is beginning, then the person also may not be discouraged with bad windows and be put off by that. So that is something to just bear in mind.
Perfect, sir. I think, would you also suggest to do a transthoracic? A transesophageal would be more informative in the post-operative valvular cases, right, sir?
Yeah, but that is not our routine practice, and I don't think that is a recommendation also. To do it routinely for all patients. Certainly, your images and everything would be good. Intraoperatively, definitely it is done for all patients. But post-operatively, unless there is a problem, transthoracic, transesophageal is generally avoided. So it is all the assessment is by transthoracic only. But like I said, if there is a problem, the windows are not good, we strongly definitely need to be sure that the valve is okay, need to rule out infective endocarditis, patient is persisting to have fever, those kind of things, then definitely yes, but not in every patient. Transesophageal would not be required.
Perfect, sir, perfect. So what's the reason of microcavitations that we see in prosthetic valves, sir?
Yeah, so it is believed that it is because of this carbon dioxide, mixed carbon dioxide in blood, because of the degassing that occurs as a result of the valve motion. So that is just one of the understandings, or one of the theories, that it is because of carbon dioxide degassing, that is mixed carbon dioxide in the blood.
Okay, perfect. So this is something like the patient management. So what agent do you use for a thrombolysis in stuck valves?
Yeah, so here we generally, again, it is all related to the patient's affordability. So the most common agent still would be streptokinase in our setup, considering most of the patients who have valves would have received valves under some charitable scheme of the government or otherwise, and hence they would not really be candidates for anything more expensive. So again, on the one side, you need to balance like what is ideal, what is with what is practical, and still gives reasonable results in our patients. So most patients would get streptokinase.
It's a continuation to the same question that I just asked. So when you come to thrombolization, so how to thrombolize when patient INR is very high? So.
Yeah, so that I think those very, what do you say, technical things which kind of vary from patient to patient, taking into consideration multiple things. In the interest of everybody, I think, Indresh, we can possibly leave it out.
Perfect, yeah, absolutely.
We'll, especially let's keep the focus to the echo assessment, the management, of course, is an ocean. And there are many things to consider in that. And I don't think there is any short or simple answer to that.
I think, yeah, so for a couple of more questions. So how do we calculate diastolic dysfunction of the ventricle in the post-mitral valve replacement in specialists?
Yeah, so this is not something that we kind of routinely do. Yeah, it's not something that we generally do, but okay. Yeah.
So in when prosthetic valve in situ, I think normally we don't comment on the diastolic dysfunction.
Generally, generally we don't. Yeah, that's right.
Okay. So I think I'll take one or two questions now. There is a lot of compliments actually, which is taking that. So there are so many questions that I think have been already answered in your slides later on. I think these questions posted before the slides come in. Okay. So is there any like why in a replacement valves in newborns and pediatrics, sir? Mitral valve?
Generally we don't replace valves in such a small. Generally, if a repair is possible, like especially if it will usually be with some other congenital heart disease, like an endocardial cushion defect or ostium primum ASD with a cleft mitral valve or something. Those situations generally would require a valve repair. So that would be the general approach. I don't think I've seen any cases where the valve has been replaced.
So the last question for the evening, I think, so how to differentiate a small pathological regurgitation to physiological regurgitation?
Yeah, so that like I just mentioned by illustrating two cases also. Physiological regurgitation, first of all, we need to kind of get that appearance in our head. I showed you about how the normal regurgitation appears like. They are usually short jets, more centrally located, and they are generally quite thin. And otherwise, the valve function, everything else is okay, but you just see some streaks of color. So that would go more in favor of a physiological regurgitation, which comes with every prosthetic valve, especially a metallic valve. Whereas pathological regurgitation, it will be more eccentric, and it will be generally to the paravalvular region. So that would be the case often. And generally those jets will be broader, and there will be other signs of pathological regurgitation that we talked about, which means a high velocity, a high gradient. It may not be really super high, but even a mildly, if you can't find any other explanation for a high gradient or a high velocity or a high VTI with a normal pressure half time, then it is something to very seriously look for. Is there a regurgitation? Especially if there is a background history of infective endocarditis for which the valve was replaced. So in those kind of patients, all the more reason to very carefully look for any leak.
Thank you so much, sir. Thank you so much again. And indeed, it is an excellent session that we had today. And on behalf of entire Philips team and all the participants, I thank you again and have a good night, sir.
Thank you all.
Thank you all the participants for your patience and connected with us for almost close to 2 hours now. And hope you all enjoyed it. And as I mentioned, you all will get the the retelecast links and in respected contacts in connections. So soon, I think we'll share it to you all. Thank you all. Thank you, sir.
Bye.